Well, my name is Jason Romero, and I'm a private practicing dermatologist here in Shreveport. I'm a 2002 graduate of medical school here and did my intern year here in Shreveport, and many of my mentors are here in the room, so I'm glad to see that. And then I've been in private practice for about 11 years now, which is in 4 kids later, so that's kind of scary. But the National Psoriasis Foundation contacted me a while back and asked me to be sort of a goodwill ambassador and educator on behalf of our patients and educating my fellow colleagues in the various medical specialties. So if this is too much minutia for you, I apologize. If it's not enough, I apologize. Hopefully it's a good kind of middle-of-the-road psoriasis state of the union address for you guys, and maybe kind of show you how we have discovered in the last 1 or 2 decades how psoriasis kind of dovetails into a lot of the general medicine and medicine subspecialties now. I am not a paid spokesperson for any of the big pharma, unfortunately, but we have to disclose that. But most of these nonprofit foundations are sponsored by big pharma, whether it's National Psoriasis or Diabetes Research Foundation, et cetera. So we have to disclose that. And most of this slide presentation was provided by the National Psoriasis Foundation, but I've sort of beefed it up a little bit for you guys. And you will or can get 1 hour of CME if you so choose to do. So I'll kind of walk you through an overview of psoriasis, or what you would see clinically, or what I see clinically, some of the clinical manifestations, the pathophysiology and histology, some of the associated comorbidities, which is what you guys will be probably most interested in, and then sort of the state-of-the-art for treatment decisions and options. So the brass tacks is that psoriasis is a chronic inflammatory skin condition. It's not a every once in a while type thing. It's something that's heritable, and there's numerous genetic loci that have been discovered now that kind of contribute to the phenotype of psoriasis. Probably 1% to 3% of the American population have psoriasis. 2% puts you at about 7.5 million. I probably feel like it's because of underreporting or misdiagnosis, it's probably up in the 10, 12 million range. Most people have a family history of psoriasis. It's a complex, multi-gene disease typically. Most people who have it have some, kind of perfect storm of genes that contribute to their external phenotype. It's got somewhat of a bimodal distribution pattern. The mean onset is in people's 20s and 30s, but then we see a smaller bell curve down in people's 40s and 50s as well. So 45 to 65, that age range, there's a second subset of people who develop it then. I hate when they give these big ranges, 5 to 30% have psoriatic arthritis. I think that's what they're saying there, is that as a dermatologist, I sort of get funneled all the worst case scenario patients who have horrible cutaneous disease but also have joint disease. So that might be the 30% into the spectrum, and then in primary care, you might see the milder cases of psoriasis who don't have as much arthritis, and that might be down at the 5 and 10% into the spectrum. But in my practice as a dermatologist, we're up there in the 30, even 40% range. So just to give you a historical perspective, unfortunately, psoriasis, leprosy, viral exanthum, systemic lupus, dermatomyositis, they were all kind of lumped together, and actually the ancient Greeks termed them all lopoi, which meant sort of a shedding of the skin. And so historically, a lot of psoriatics and other systemic diseases that manifest on the skin, they were all thrown into the grab bag of lepers. And so whether you look at the Quran or the Torah or the Old Testament of the Bible, when they're referring to leprosy, oftentimes these people had psoriasis or dermatomyositis or lupus. Leprosy is a contagious disease, but it's not really highly contagious person to person. We think it's more in rodent feces that get aerosolized. And so a lot of psoriatics were shipped off to leper colonies and subsequently might have developed leprosy, but unfortunately, even here at Carville in Louisiana, one of the famous leper colonies that was started in the early 19th century, probably a lot of psoriatics ended up going there. And because they didn't have the same horrible disease progression that a lot of lepers had, some of these people with psoriasis and lupus ended up being the nurses and caregivers to the true lepers. When science and medicine were kind of coming out of the Dark Ages into the 19th century, there were various medical centers, whether it was in Vienna, Germany, Paris, France, London, England. And so there was a famous physician, Ferdinand von Hebra, that if you see a lot of these old, beautiful artistic plates of various diseases, this guy, Hebra, really was the founder, one of the founders of dermatology or modern dermatology, and he would hire the best artists of the day to draw these beautiful depictions, color prints of cutaneous manifestations of disease. And so Hebra and some other contemporaries started to kind of separate out, well, psoriasis does this and looks like this, leprosy does this and looks like this, lupus, dermatomyositis, and so on. So believe it or not, it wasn't until well into the 19th century that some of these diseases were separated from each other. Immunologically, psoriasis is a Th1 dominant disease, and a very common comorbidity is seronegative asymmetric oligoarthritis. So for the med students and residents looking to take boards, those are kind of buzzwords to differentiate it from, say, rheumatoid arthritis, which would be more symmetric and poly joint arthritis. So we'll walk through some of the clinical manifestations. So some of the terminology we use, we might speak of patches, which would be large flat areas, macules, which would be 1 centimeter or less flat areas, papules. There's sort of macules and papules mixed in here, but papules would be sort of the raised form of a macule. Plaques, so large raised areas would be plaques. Desquamation and erosion can occur. Sort of a destructive or arthritis mutilans can occur with psoriasis. Onycholysis, which is sort of a crumbling and destruction of the nails. Here's somebody with plantar psoriasis, large plaques. And then you can have these, one of the hallmarks of psoriasis is that silver scale. And we'll see that histologically in just a bit. So most people agree that there's probably 7 main subtypes of psoriasis. The most common being the plaque psoriasis. There's a pustular form of psoriasis, hand and foot or palm and sole, palmar plantar psoriasis. There's inverse psoriasis, guttate psoriasis, erythrodermic psoriasis, and nail psoriasis. So over 80% of the people with psoriasis will have this sort of common plaque psoriasis. Its hallmark is that silvery scale, and basically the epidermis is turning over so rapidly and the stratum corneum is so thick, and then air gets trapped in between the layers of the keratinocytes in the stratum corneum, and it gives it that silvery appearance when the light strikes it. And so knees, elbows, scalp, the periumbilical region, and the presacral region on the lower back. Those are all sort of the common areas for common plaque psoriasis. And there's just a little picture depicting that scalp presacral region, periumbilical, knees and elbows. Pustular psoriasis probably affects 1 or 2% of patients. You get these yellow, white, 1 to 2 millimeter pus-filled lesions, and these are actually sterile pustules. So it's caused by a huge extravasation of neutrophils into the epidermis and stratum corneum, and so you'll get these 1 and 2 millimeter sterile pustules in the epidermis. It can start as plaque psoriasis with pustules forming at the plaque margins, and typically this will occur with rapid withdrawal of corticosteroids, but then for board exams, they always love to pop you with beta blockers and lithium. Those are two common. So usually it takes somebody who's already got psoriasis and maybe they're started on lithium or started on a beta blocker, and it kind of converts their common plaque psoriasis into that pustular form of psoriasis. And then what you guys may see in the outpatient clinics, if you have somebody with psoriasis, you hit them with a short course of a high-potency corticosteroid, whether it's a celestone shot, say for sinusitis, or you might need to put them on a Medrol pack with an antibiotic for bronchitis. Well, those are very strong steroids, but short-acting, and as their body naturally sort of weans them off, their psoriasis sort of has a rebound effect and flares, and then it can convert into pustular psoriasis. So this is just depicting those little 1 and 2 millimeter sterile pustules. And what eventually happens is these areas sort of become denuded and eroded, and so you end up very much like with somebody very much like a burn patient, where they've got deeper layers of skin that are sort of prematurely exposed to the outside world, and then they're set up for secondary infection and problems you would see in burn patients. Another subtype of psoriasis that's very common is palmar and plantar psoriasis. So it can range from sort of more discrete plaques or more diffuse scaling. I tend to see it a lot in either females, stay-at-home moms that are constantly washing their hands. That soap and hot water irritation tends to bring on psoriasis, but also people in the medical fields, scrub techs, scrub nurses in the OR, people that work in restaurants. I've got people who are executive chefs here in town that have trouble with this just from the constant hand washing and handling of foods and things. And then a subtype of that palmoplantar psoriasis is a palmoplantar pustulosis. And so what you will see are these discrete, little pustules, and then as the neutrophils go through apoptosis, you'll get these little brown areas, and basically that's collections of dead neutrophils. So kind of knee-jerk reaction, most people in the primary care world see this and say, oh, you've got tinea pedis or tinea manum, and really this is psoriasis. So tinea doesn't typically cause pustules. Sometimes it'll cause clear, large vesicles, but if you see pustules on the palms and soles, think psoriasis. Inverse, meaning sort of the opposite of what you would typically see. So inverse psoriasis, you'll see it in the intergluteal regions of the gluteal folds or inguinal region. Under the breasts is very common, in the axillary area. So it's psoriasis, but oftentimes you can have sort of concomitant Candida infection. So we all learn in sort of our basic sciences in med school to look for those satellite papules and pustules that sometimes can signal Candida infection. So often it's secondarily infected with Candida. So you'll treat for the psoriasis, but you may also cover with something like diflucan or nystatin to treat the Candida as well. Guttate psoriasis, so gutta is Latin for raindrop or water droplet, and so these guttate macules where you'll see 1 and 2 centimeter macules and papules. Some of them will have that silver scale. Typically in children, so this is that strep superantigen that we learn about early in medical school in microbiology. So strep pharyngitis, it's very common to trigger that in children. And so typically in children, it will clear within a 6 to 8 week time frame with treatment for strep. Adults who get it tends to linger or go away and then remanifest itself as psoriasis, plaque psoriasis. Probably, luckily, uncommon, but most severe form of psoriasis is erythrodermic psoriasis. So sort of like showed before with pustular psoriasis, where you can lose those top layers of epidermis, and it's similar to a burn patient. Same thing here, but even worse, where they start to sort of desquamate all over. And once again, it's often triggered by medication change, whether it's withdrawal of corticosteroids or initiation of beta blockers, lithium. I guess one of my little acronyms was BAIL, B-A-I-L, so beta blockers, anti-malarials, interferon, and lithium. So if somebody develops pustular psoriasis or erythrodermic psoriasis, they're going to need to be bailed out. So that's a good little mnemonic for your boards. And then another common thing that we see, usually along with one of the other forms of psoriasis, will be nail psoriasis. And so for exams, question writers love to use the buzzwords oil spots and nail pits. And so you'll see on this next photo, you see these little pits, almost like somebody took a ballpoint pen and put little discrete, depressions in the nail, and then these oil spots. And so this phenomenon is caused similar to the palmoplantar pustulosis. There's neutrophils that have extravasated through the nail bed and have died, and so they just sort of oxidize and develop this brown color. And then the pits themselves start when the nail is way back here under the cuticle, and they're little microscopic psoriasis plaques, basically. And then as the nail grows out, what would be, say, on the skin, the silver scale of a plaque psoriasis, that falls off the surface of the nail, and you get this little depression. Here's another famous historical physician, Heinrich Kebner. He was a German physician way back when, and he termed this phenomena called the isomorphic response. So it can be seen in a lot of different entities, whether infectious or immunologic. Dealing with psoriasis, what people can do is scratch an area or injure the skin, and usually 2 to 3 weeks later, psoriasis comes up in those areas. So we call that the Kebner phenomenon or the isomorphic response. But you can see that sort of with auto-inoculation with warts. If somebody has warts and they scratch one wart and then you get a line of warts down the arm. We see it in lichen planus, systemic lupus. So there's quite a few places where you can see that. And that was another differentiation where, when we didn't have electron microscopy and even standard microscopy, lepers didn't do this, but psoriatics did. So they would use things like this to try to differentiate the various diseases. So symptoms of psoriasis, as you can imagine, if you're covered with large scaly plaques, they're going to itch, they're going to burn, they're going to sting. And then one of the other buzzwords for the board's the Auspitz sign. So if you prematurely peel the surface of a plaque of psoriasis off, you'll get these little pinpoint hemorrhages. And so that's called the Auspitz sign. Constant itching is a very frustrating symptom for a lot of people. The National Psoriasis Foundation is always sending little patient questionnaires out throughout the year, and unanimously most patients complain of self-consciousness, embarrassment. They actively conceal their psoriasis, pain. So when the skin is thick, especially over joints, it becomes less pliable or less flexible. So, if you get somebody who's got a really bad flare on the arm, they bend their elbow, their skin cracks open, and there's bleeding and secondary infection sometimes. So it's a very distressing disease process. So, ergo, a lot of people can get depressed and anxious about it. Negative impact on work productivity, job retention, missed work days. It's a large financial burden for some people as well. Same thing, market research by the private pharma companies. They come up with the same data. Most people trying to hide their psoriasis. Intimacy is a problem. Imagine, the Kebner phenomenon can occur just about anywhere. So if you've got it in the genital region, not good for marriages or relationships. Sleeping problems, just constant itching all night, flaking everywhere. Not a fun thing to have and to do. When questioned about where patients would put their psoriatic disease in comparison with maybe other concomitant illness, they rank it right up there with other chronic medical problems. I'm kind of skeptical about the MI. If you ask the psoriatic person while they were having an MI what bothered them worse, it'd probably be their MI. But it is something that's very distressing, especially if they develop arthritis along with it. Histologically or pathophysiologically, to date, they've found about 40 different genetic loci. There's relationships between inflammatory bowel disease, especially Crohn's disease, ankylosing spondylitis, coronary artery disease. The boards always like to question about this human leukocyte antigen B27. That's a commonality among a lot of the rheumatoid diseases, but especially these three: Crohn's, ankylosing spondylitis, and psoriasis. Most people have some family history. There's a heightened risk factor if there's one parent versus two parents. Environmental factors like Kebner phenomenon, any kind of skin injury. If somebody's got an underlying predisposition to psoriasis, but they've never exhibited it yet, sometimes things like a burn or some trauma to the skin will sort of unmask their psoriasis. And then once again, that beta blocker, lithium, anti-malarials, and interferon. See a lot of people being treated for hepatitis or malignant melanoma, and then that will sort of unleash their psoriasis. So, and then of course, smoking, alcohol, those all institute higher inflammatory states in the body and can unmask psoriasis. So histologically, it's sort of one of those neat diseases where if you look at a cross-section of the skin, you can actually see with your own eyes sort of what's going on. You've got these rapid keratinocyte proliferation where the basal layer migrates up to the stratum corneum just overnight, seemingly. You get elongation of these reedy ridges. So typically the skin's got these mild little waves, and then with psoriasis and the inflammation, you get these elongated reedy ridges. You get a dilatation of the microvasculature in these reedy ridges. You get sheets of T lymphocytes, those Th1 T helper cells, and then you get an extravasation of neutrophils up into the tips of these reedy ridges, and that's what we call Potrier's microabscesses. Dr. Fowler probably has thrown that on a few exams. So because there's so many different genetic determinants, there are different points at which psoriasis is probably initiated, but just as a general schematic, there are these sort of primitive monocytes that reside in the surface of the skin. They're called Langerhans cells. They're sort of a primitive macrophage or monocyte. And we think that sometimes those Langerhans cells are inappropriately activated and signal circulating monocytes to then go to the lymphatic tracts and lymph nodes and activate those Th1 T helper cells. And then those T helper cells, there's expansion, release of interleukins and cytokines such as TNF alpha, interleukin 23, IL-17, IL-12, and then it's those interleukins and cytokines that sort of drive this inflammatory response and this upregulation and proliferation of the epidermis. And so this is sort of a good depiction of sort of what's going on. This would be, say, that monocyte in the epidermis, that Langerhans cell, that's, either appropriately activated because of an infection or a superantigen, or it's got a genetic fault where it's inappropriately activated and it starts churning out inflammatory mediators. And so it signals a circulating monocyte to then go to the lymph nodes, activate those Th1 cells. There's some subsets of T helper cells, 22 and 17, that are also activated. And then one of the recurring themes is that TNF alpha. So, and then some of the other targets for the newer medications, IL-17, IL-21, IL-22, 23 here is a big one. So you get this sort of positive feedback loop eventually, and it's just sort of an out-of-control situation. Another sort of histopathologic view, you get these elongated reedy ridges, you get these sheets of Th1 lymphocytes, micro abscesses up here, and so that's what you saw with the palmar-plantar pustulosis, the pustular psoriasis. Eventually, if there's a large enough inflammatory neutrophilic infiltrate, these will kind of collect further up in the stratum corneum, and you'll see these pustules, but they're sterile. So they're not there fighting infection. They're there because these T lymphocytes are driving them up to be there. And then you get, you can kind of see the lumens of some of these little arterioles as they go up into the skin. So if you accidentally prematurely scrape off all this skin debris, you'll see these little pinpoint hemorrhages, and it's because the arterioles are coming all the way up to the surface of sort of the granular layer. Associated comorbidities, so this is where, my brothers and sisters in internal medicine and its subspecialties come in. Psoriatic arthritis is probably the big ticket item on the list, but inflammatory bowel disease, especially Crohn's disease, uveitis, renal disease, hepatosteatosis, COPD. It's associated strongly with sort of metabolic syndrome, obesity, hypertriglyceridemia, glucose intolerance. So a lot of my patients, especially in their 40s and 50s, have that sort of metabolic syndrome. But, like I showed you that schematic of the immune process going on, imagine this same process is sort of taking place in the lining of the large intestine, in the lumen of your coronary arteries, in your filtering tubules, in your ductules, in your kidneys, in the parenchymal cells and ducts in the liver, so that there will be slightly different subsets of T cells and even B cells in some of those other organs, but this same inflammatory type cascade is going on, and that's why some of those same new biologic agents are used in these various disease processes, because they're knocking out some of these same inflammatory mediators, these TNF alpha and interleukin, especially 12 and 23. Once again, dyslipidemia, obesity, all that sort of metabolic syndrome picture. And I have quite a few patients that are referred to me by primary care They may have glucose intolerance, but have never had any kind of cardiac workup. They've got horrible psoriasis, and usually the next stop for them, as far as I'm concerned, is cardiology. And we've caught some disasters waiting to happen. People ended up, a week later, being stented and things like that. So, one of the real troubling, further comorbidities of just plain cutaneous psoriasis is psoriatic arthritis. Up to 30%, certainly in my clinic, maybe not as high with primary care and more mild cases of psoriasis, but you can get this arthritis mutilans similar to rheumatoid arthritis. Most psoriatic arthritis patients develop it, a good 12 years after they're diagnosed with psoriasis. But there is a small percentage of patients who develop psoriatic arthritis before psoriasis. And so they've always been lumped into the seronegative spondyloarthropathy. So, the rheumatologist for a long time didn't know what to do with these patients because they didn't really have an identifiable serologic marker to put them into rheumatoid arthritis or lupus or dermatomyositis. And so a lot of these people rocked along kind of, being undertreated and then would develop these, kind of destructive telescoping joints. And so now that we know that some people develop psoriatic arthritis before skin disease, we tend to be much more proactive. And then another term, you may see this on your medicine boards, enthesitis. The powers that be know that not every doctor is going to go x-ray the joints, and there might not be a lot of joint change even in early cases of psoriatic arthritis, and there's not a serologic marker you can really study. But enthesitis, which is sort of a swelling of the tendon insertion, say at the olecranon process or the Achilles tendon insertion into the heel, a lot of times that's an early marker where people will be kind of tender and swollen there before you really see identifiable joint changes. So this is a very common presentation that I would see where you'll see kind of mild plaque psoriasis over the DIPs and maybe PIPs. And this picture is kind of stretched out, but it's trying to show you, especially this fourth digit. It's what we would call like a sausage digit. It's sort of lost its normal hourglass shape around the joints, and there's a lot of inflammation there. And there is a very strong direct correlation between psoriasis on the backs of the hands and the incidence of psoriatic arthritis occurring. And so remember, it's that asymmetrical oligoarthritis. So it tends to strike these DIPs and PIPs first, whereas rheumatoid arthritis is often symmetric and it'll attack more the MCPs first. And so another buzzword for the boards, this pencil and cup deformity. So you get a sort of a destruction of the normal sort of rectangular or squared off tip of the phalanges, and you'll get this sort of pointed appearance. And it's just, the osteolysis going on there, and you'll get total destruction of the joints. And you can see this person's got that sausage digit, very swollen. So a lot of times it'll be one or two fingers, but all the other ones are unaffected. There's a screening tool. It's not, real easy to do in the office to stop and do questionnaires and things in the middle of exams, but it just sort of, it's good to do every now and then to find out where your patient's at in that point in time. So, have you ever had any swollen joints? Has your doctor ever told you that you have arthritis? Do your fingernails or toenails have holes or pits? Have you had pain in your heels, so that enthesitis? Have you had a finger or toe that was completely swollen and painful for no apparent reason? And those are common presentations of psoriatic arthritis early on. And so I keep a sticker around. I'm not great about keeping up with this, but I have a few patients that I know that I need to kind of keep this on, because once or twice a year they'll come in with like a random toe is swollen and purple, or one of their fingers has gone sausage digit on me. So it's just good for my own memory to remind myself where they've had previous flares. Once again, kind of touching on the comorbidities, I didn't come up with this. Somebody played cutesy and found a heart-shaped psoriatic plaque, but that metabolic syndrome, hypertension, smoking, atherosclerosis. This was a small study done back in 2011 with six patients with mild to moderate psoriasis against 4 controls, and they did a PET scan, and they just saw an increased uptake of the fluorodeoxyglucose in the lumen of the arteries, in the parenchyma of the liver, the kidneys, the inferior aorta. So, like I was saying, some of those same inflammatory processes that are going on externally can be occurring in the lumens of arteries and the ductules and the kidneys and the liver. Again, increased risk of MI. So this was a prospective study out of the UK, and fairly old study back in 2006. Since then, if you do a PubMed search, psoriasis and comorbidities, hundreds of articles to sort of verify some of these early findings. But MIs per 1,000 patients, healthy controls, they had a pretty large power in this study. Average population 3.5 per 1,000 patients. Mild psoriasis, they saw an uptick 4 per 1,000, and then severe psoriasis 5 per 1,000. And this just sort of shows the younger the patient, the higher the risk of MI and coronary artery disease. So a lot of these young, this is where we can catch a lot of these young 20 and 30-year-olds with that metabolic syndrome. And if we treat them proactively, maybe get these points down lower. I threw this in here once again to kind of hammer home, there's a slightly different inflammatory infiltrate in the gut in something like Crohn's disease, but similar process to what's going on in psoriasis externally is going on in the gut here, and that's why some of the same immunomodulating agents are used for these various autoimmune diseases. Current treatments, so sort of the state of the art, we base them sort of how severe is the disease. Mild and moderate patients, we might use topical medicines or topical and one systemic agent. Moderate to severe patients, especially if they start to exhibit signs of psoriasis, then we really get more aggressive and might move on to systemic agents, or sometimes piggyback to systemic agents. As a general rule, we consider, sort of like in burn, Dr. Satig taught us, a palm might be 1% of the body surface area. So three palms is sort of mild, 3 to 10 palms is moderate. Anything over 10 is going to be severe, especially if they exhibit arthritis. And so some of the classic treatments have been topical. So topical corticosteroids, vitamin D analogs. So vitamin D sort of regulates that rapid cell turnover that's occurring in psoriasis. Retinoids, once again, there's some receptors called the retinoic acid receptor on the DNA in individual cells, and these retinoids sort of bind to those receptors and control that hyperproliferation going on. TAR is an old treatment, not used as much anymore, but it was sort of one of those things developed back in Hebra's days, that there's a lot of compounds in coal tar extract that have immunosuppressive effects. Anthralin and calcineurin inhibitors. Orally, you might know it as cyclosporin. Topically, there are some topical calcineurin inhibitors. systemic therapy, so acitretin is sort of a cousin to Accutane that we would use or isotretinoin that we would use for severe acne. Well, acitretin can be used to control that cutaneous proliferation. Cyclosporin, calcineurin inhibitor, methotrexate, that dihydrofolate reductase inhibitor, apremilast is a prostaglandin inhibitor, and then so the new state of the art is this whole world of biologics. So TNF inhibitors, if you remember from the diagram we looked at before, TNF is a common sort of instigator or signaling modulator. And then some of these new, anything with AB on the end is sort of an antibody that has been trained to either bind to receptors or bind to circulating interleukins. Topically, once again, steroids, salicylic acid, tar, emollients, vitamin D analogs, vitamin A derivatives. Phototherapy for decades and decades has been sort of a gold standard treatment. The problem with phototherapy, it's like one of those first do no harm type things. There's a double-edged sword. Phototherapy, what it does, especially this narrow band 308 to 314 nanometer UVB, it suppresses those sort of primordial monocytes, those Langerhans cells in the epidermis. So it's got an immunosuppressive effect, but at the same time, it's got a potentially mutagenic effect to keratinocytes and melanocytes. So you see an uptick in squamous cell carcinoma, melanoma, after years of possibly treating somebody with phototherapy. So we do use it, but we use it along with other modalities so that we're not just relying on light therapy. And then this is sort of the state of the art. I'm sure a lot of you guys are familiar. Infliximab was one of the first ones, and I was at a meeting about a year ago and was in a talk given by a dermatologist, but there was probably about 15, 16 years ago in Chicago, this particular male dermatologist, his wife was a GI fellow, and she was participating in some of the early studies of this drug. I know I'm not supposed to use the brand names, but of this drug in treating Crohn's disease and ulcerative colitis. And some of those patients also had psoriasis. And she noticed that their psoriasis went away, so she went home to her husband, who was a fellow in immunodermatology, and said, hey, we've got these patients with Crohn's. We're treating them with this new biologic medicine, and their psoriasis is disappearing. And so his department got with that particular drug company, and the rest is history. It's sort of blown up since then. This one has been a great one as far as treating rheumatoid arthritis, psoriatic arthritis, and cutaneous disease. It's sort of blown them all away, even the new ones. This one, etanercept, is great too. It's got a higher frequency of administration. Usually people do it twice a week and then eventually back off to one shot a week, whereas adalimumab is once every 2 weeks after the loading dose. Ustekinumab is an IL-23 blocker. So these are TNF-alpha blocking agents. So they're antibodies that sort of go around and bind to TNF-alpha and try to take them out of circulation. Ustekinumab binds to interleukin 12 and interleukin 23, tries to take that out of circulation. It's an every 3-month shot, which is great for some people. It helps their arthritis, I don't think as well as adalimumab, but some people are willing to have a few little aches and pains to only have to give themselves a shot every 3 months. And then these are 3 new ones that have been launched in the last year or so. They're all And then if you look at like the National Psoriasis Foundation website or the National Rheumatoid Arthritis Foundation websites, they do a good job of posting what drugs are in studies right now, phase 1, phase 2, phase 3 studies. I mean, they're just more than you can count. They all still have like code numbers. None of them have been named yet, but they're even trying to put biologics in topical formulations, which probably wouldn't do much for deeper joint inflammation, but would help cutaneous disease, maybe even help things like cutaneous lupus and things like that. So. Current treatment patterns, obviously if you've got a milder case of psoriasis, some people don't even complain about it, but the vast majority of people will be on topical medicines, sometimes an oral agent, but mostly they're going to fall in this topical. Moderate, still the vast majority will be in that topical category. Moderate to severe, and especially with arthritis, still some topicals, but then you see biologics kind of creeping in more and more. This panel dealing just with psoriatic arthritis, I kind of feel like the oral topical and the biologic topical are kind of flipped now. This study was 2014, so just in the past few years, I think we're seeing a whole lot more people on biologics and topicals, and clinicians are starting to get away from methotrexate and Imuran and cyclosporin just because of it's just harder. Those medicines take the shotgun approach and sort of suppress the whole immune system. These new biologics target those certain aspects or those certain interleukins that are raging out of control. So, and most of our patients end up being on a statin or some other agent that's processed by the liver. And then if I want to start methotrexate or cyclosporin or Imuran, you start worrying about drug interactions, inflammation of the liver, renal function, those sorts of things. So we've got almost 18 years of safety data now for the biologics, and I've definitely probably seen more disasters with the older immunosuppressants than I have with any of the biologic agents. Factors involved in treatment decisions, kind of commonsensical things. Is the patient going to stick with it? Are they going to follow up for labs? How severe is the disease? Ease of treatment. Are they willing to give themselves 2 shots a week, or would they rather a medicine that's an oral medicine once a week, like methotrexate, but then they have to get labs checked every so often? So, and then insurance coverage, obviously. As you know, the biologics are awesome, but extremely expensive. So, psoriatic disease. So what we try to tell patients, especially patients with, comorbidities, especially arthritis, coronary artery disease, psoriasis is a chronic illness, just like high blood pressure or diabetes. So a lot of times what happens is I'll put people on some modality of treatment. They'll get better, and they see no external manifestation of their psoriasis, and then they're in saying, I'm cured, can I stop everything? And I'm like, well, no. It's no different than if you were a type 1 diabetic and your glucose was great for a while, you can't just stop your insulin. I mean, your disease is not gone. So, the National Psoriasis Foundation, being sort of patient advocates, really wants us as clinicians to come up with treatment targets, letting patients know that there's new treatments available to make their moderate and severe psoriasis very mild, so just kind of give patients hope. And then prospectively, there are a lot of studies going on looking at, well, if we started somebody at age 20 with metabolic syndrome on adalimumab, and they've been on it for 15, 20 years, how much have we lowered their risk of MI or how much longer out have we pushed their glucose intolerance where we don't call them a diabetic yet. We might be modulating a lot of these comorbidities as well as the psoriasis and arthritis. So most of that stuff is informational, convincing people if they've, after 3 months, we might be able to get them down to less than 1 palm lesion of psoriasis. And then usually I'll follow, and this is dealing more with the biologics, usually I'll check in on patients every 6 months when they're on a biologic. This just gives you an idea where you can go if you want to do any other extracurricular CME on psoriasis or psoriatic arthritis. That's it. Any questions? Or?
Jason,
Yes, sir.
2 questions.
Yeah.
Considering the metabolic syndrome and the variety of comorbidities, should biologics be used more frequently in patients with lesser degrees of skin disease? The other question is, has the direct consumer advertising, and I'm sure all the advertising the primary care physicians and dermatologists get for these very expensive agents, skewed the treatment to a population that probably doesn't need biologics, but could be treated with lesser, yeah.
I'll take the second question on first. I don't think so, because I don't think that we're treating people who don't necessarily need it. A lot of the drugs that we see advertised are drugs looking for a disease, but these biologics, there's definitely horrible disease out there, but it's so onerous on clinicians and my nursing staff to get approval for these medicines that certainly in me, and I don't see anybody else sort of doling it out like candy just because their patient saw a commercial.
And I don't,
and
not you, where know you're in a high quality practice,
yeah.
but sort of in
yeah. Well, just even on a national basis, the insurance companies are so reluctant to approve these that just the work that the patient has to go through and the clinician and the staff, even in a rural primary care setting in Manning, Louisiana, there are certainly plenty of patients down there that need biologics that can't get them. But I haven't seen that second question. First question, when I've been asked that before, and it's sort of like when Prozac came out in the late 80s and people were like, well, maybe Prozac should be in our drinking water. It's the greatest thing. Sort of like that with biologics. I do think that if these medicines were a lot more affordable, there are probably other places that we could initiate them in the milder cases of psoriasis that also have severe metabolic syndrome. Hopefully in that laundry list of drugs in different phase studies, maybe there will be one that's easier to manufacture, that's less expensive. And so I'm certainly not a defender of big pharma, but in the case of biologics, they have to get pooled plasma from all over the nation, and as you know, plasma is the one thing that plasma donors can be paid for, so it's not like blood donation that has to be just a donation with no monetary exchange. Most people go in and make $50 or $100 on their plasma, and so pharma has to buy all that already expensive plasma, and they pool it, and filter it, and make sure that there's no Hep C or HIV involved. And then they have to break these antibodies apart and then reconfigure them with their newly programmed antibody that'll go attack TNF-alpha or the interleukins. And so that's why in Obamacare there was that big battle in there about the biosimilars. There are these generic companies that would like to get less expensive biologics to market. But do you want to be giving yourself a generic biologic that was made in, India with no FDA oversight, and who knows where that plasma is being pulled from? Are they monitoring it for hepatitis and HIV and those? So, it's a tough call. Would I like there to be generic biologics? Yes, but you got to weigh the risks of some of the importation of maybe knockoff biologics. Could be kind of scary. So, but I do think that this is the frontier in internal medicine and rheumatology and cardiology. The immune system and figuring out how to modulate the immune system without causing other unforeseen disasters. I kind of think of it like, Robert Oppenheimer's, infamous speech with Franklin Roosevelt, and he was getting the final okay to test the nuclear bombs out at White Sands in New Mexico, and Roosevelt's cabinet members said, well, Dr. Oppenheimer, what's the worst thing that can happen? And Oppenheimer and his physicists said, well, theoretically, we could start a chain reaction that ignites the whole atmosphere, and that would be the end of humankind. But we don't think that's going to happen. And I think that's the same with the immune system. Like, we have to carefully kind of decide which, interleukins and cytokines we mess with, because we don't want the whole house of cards to kind of collapse, But I do think the immunology is sort of the state of the art right now for a lot of disease, whether it's metabolic syndrome or not. Somebody in the back.
I'm a rheumatologist, and I take care of patients with psoriatic arthritis a whole lot in my clinic. And
yes.
Your talk was excellent. I just wanted to bring up the point that we use DMARDs, and a lot of DMARDs we were using gold charts and whatnot. They all have fallen out of favor. But methotrexate have been such a time-trusted friend.
Yeah.
We do have lots and lots of patients on methotrexate, rheumatoid arthritis, psoriatic arthritis. Some of them have been on medication for 30 plus years. So I just see that as, in general, I understand the metabolic syndrome concern and use of statin, and patients should be screened for hepatitis B and C. And there are females of reproductive age in which we are worrying about putting them on methotrexate. But I still believe it's one of a very good drug in the DMARD, which helps psoriatic patients the most. And as dictated by insurances, they don't want to give you biologic till you have tried a DMARD.
Right.
So what I see is that when patients see a dermatologist and they get talk about methotrexate they use, and because of the concern of hepatotoxicity in these patients, in the past there used to be liver biopsies done, which sounds very radical now. And I still feel like the word of dermatology is much more scared of methotrexate compared to rheumatologists. So
yeah, I think it's kind of I still use a lot of methotrexate, even in kids, and cyclosporin and Imuran. I think it's a generational thing. There are older, I don't mean older, but like Dr. Winder, who you were sitting next to a minute ago, he still exclusively used methotrexate up until his retirement. But then you've got a younger generation that probably came into practice after me that grew up with biologics, and so it's like, did you grow up with a Nintendo or a MacBook Pro? I'm comfortable with methotrexate, but I think a newer generation of physicians are a little more scared of it. But I still use those, and I'm certainly not, on the shill for the biologic companies. But once again, I think if their price point was down there with methotrexate and just their safety profiles are great, but methotrexate is certainly one of the arrows in my quiver.
So I think on one side, if you put patient on biologic, yes, you have less lab monitoring and things to begin with. And if we live in an ideal world, we'll just want to move that magic wand and get biologic approved.
Yeah.
But we know how much paperwork it involves. So
right.
I think the take home should be that if we can use methotrexate, we should use the optimal dose and try that for our psoriasis patient, while still they are miserable with the rashes and all that. And then add the biologic on if we can get it, we are lucky. And sometimes a patient desperately needs biologic and it's not getting approved. We stay at the forefront of that with the patients here.
Yeah, I agree. I mean, we definitely, do what their finances will allow, and but yeah, I wholeheartedly agree with you.
Are you using secukinumab with a psoriasis patient that concerned of worsening of IBD? Is that something which is causing more problem now using secukinumab because there is worsening of IBD associated with that?
Yeah, that's one of the, back to that whole interplay of the immune system. I haven't seen it a lot in my practice, but I know how large the GI patient population here is at LSU, so y'all probably get funneled some of those, odd cases. And I've even had some IBD patients on, infliximab whose psoriasis worsened. So there are those oddballs, but I haven't seen a lot of it, and it hasn't changed my practice pattern or anything. Yeah.
For all the general medicine residents and interns who, we see a lot of mild, moderate psoriasis who. What are your go-to cost-effective topical treatments that for our patients? Most of us we can't get our patients to see video or dermatology.
Right. So, as you know, in this crazy, world of pharmacy and medicine now, even the generic drugs, those manufacturers are price gouging, and then the corner store pharmacies then also try to price gouge. But generally, triamcinolone is a mid-potency topical corticosteroid. That's a good, starting point. Fluocinamide is sort of next up on the rung. That's still pretty affordable. And then clobetasol and betamethasone are generics that, depending on the pharmacy you check with. We have a lot of luck with the Right Care across the street from you guys. They're good about finding the best prices on generics, but then they also track down manufacturer coupons to keep name branded things low in price. So a lot of your patients can check with the Right Care pharmacy. And but those three topicals, methotrexate is pretty inexpensive still. The lab monitoring, that might be an extra added cost, but a lot of people with moderate, even mild and moderate psoriasis, if you've got 1 or 2 palms, that's classified as mild, but if it's on your palm, that can severely affect your quality of life. So there are a lot of people, depending on the location of their psoriasis, we may be more aggressive with a topical and methotrexate. And so, hopefully, if you guys rotate through the room clinics, you'll get, somewhat comfortable with prescribing methotrexate, and that would be, so she's right. I mean, it's not anything to be scared of if you're monitoring it correctly, but you have to watch your patient population. If you've got people that are going to take it but not show up for labs, and you just have to watch them closely. Any other